Okay, so we might get started. My name is Ridia Lim. I'm chairing this session. Welcome to the session, everybody. This promises to be a fantastic session with our many invited speakers speaking today. Firstly, I'd like to just let you know that you can ask questions via the Congress app, so please do that. I'll be receiving those here. Our first speaker is Donald Tan, who just gave an incredible lecture as the Cornea Update lecturer. Professor Tan is from Singapore. He's a global leader and has made major contributions to the field of cornea, external eye disease, myopia, and refractive surgery. He's a clinical professor at the Duke National University of Singapore. Professor Tan is a founding doctor and a previous medical director of the Singapore National Eye Centre. He founded the Asia Cornea Society and is the immediate past president of the Asia Cornea Society. His innovative mind is clearly evident in the lectures he's given so far. I'm looking forward to this talk. His clinical controversy is the controversy of doer's layer. Why should we bother? Welcome.
Thank you very much. So I was asked to participate in this clinical controversies session. I was thinking, what is so controversial in cornea? Because we're a pretty close bunch and we're all friends. And I thought of the one controversy over the last, I think, decade or so, in which it's generated a lot of interest. And this is the problem of corneal anatomy and the controversy of a new or novel layer of the cornea, the sixth corneal layer. And it's named Duer's layer because of my good friend, Professor Harminder Duer from Nottingham. He's a brilliant corneal clinician scientist, and he's had a lot of issues about the controversy of this layer, and I'm hoping to share with you in the next few minutes exactly why, how important is it actually a layer, and why we should bother, and we should. So his paper came out in Ophthalmology in 2013 with a really interesting and I would say fairly provocative title, Human Cornea Anatomy Redefined. Now that's a pretty good title for an article. Novels there, a novel predestimate layer, brackets, Duer's layer. And it was essentially stating that we had a discovery of a new layer in the cornea. It was an eye bank study of the plane of dissection of big bubble Dauch. So for those who are not aware of big bubble Dauch, it's for patients who have corneal stromal disease and normal healthy endothelium in which we inject air deep to separate a cleavage plane between the stroma and Descemet's membrane. And that's the gold standard for example, keratoconus. This is an eye bank study in which he challenged the concept of where that bubble separation was. And the main separation was not, as what we thought, between the posterior stroma and Descemet's membrane, but was between the posterior stroma and a novel, well-defined acellular layer in the predescemetic cornea. And he demonstrated that quite aptly. Here is a big bubble separation. Oops, sorry, let's go back. And you can see Descemet's layer, that dark gray layer. There's another layer there right next to it, Duer's layer. And you can see in the scanning and electron microscopy, Duer's layer there. He stated there were major implications, not only in corneal surgery, but also in glaucoma. So this created a huge buzz, not only in the professional community, but also in the press. These were sort of articles in Optometry Times, sixth layer discovered, new layer in the human eye discovered. And of course, it generated quite a bit of interest. A few months later, a reply to Ophthalmology came out. And this was from a group in which they queried this article. And they said, "Dear editor, we read the recent claim of the discovery of a new corneal layer by Duer et al. With incredulity." So I thought that was a really interesting phrase. And they went on to state the existence of a predestimate stromal layer remaining after tissue. He said tissue remaining after pneumodissection is well known. And the authors had a previous publication published in Cornea 3 years ago, before that, in which they described the exact same thing, dissection plane in the deep anterior lamellokeratoplasty using the big bubble technique. And basically they said this was just stromal remnants. They went on to say that this is their further investigation states that this stroma, it's just stroma, and it is not a new layer. So to cut a long story short, this was the issue, and there were to and fro, and subsequently at many corneal meetings, this was discussed. Is this a layer or not? Is this new or is it not new? The key issue is really, it's not so much of semantics. So is there a layer, and is it something real? That's the first question, which is not so much so important as the key point is, and if so, so what? All right, so that's what I'm going to address. I'm going to change topic now to area of anterior stromal dystrophies. And we all know that after we do a DALK surgery where we've replaced the stroma completely, you can get recurrence of the particular stromal dystrophy within the stroma itself, within the graft or around the graft. So if you look at granular dystrophy type 1, for example, the granular deposits recur almost exclusively in your posterior host stroma, the residual stroma after a non-Descemet's bearing DALK. So in other words, if you remove most of the stroma, but you leave some behind, that's where it recurs. And that makes sense because you've left some behind. But it can also occur anteriorly in the subepithelial planes. For lattice, much the same thing. So this is lattice dystrophy type 1. Again, if you leave posterior stroma behind, then of course you're going to get recurrence of lattice in that layer. And because of that, we are now telling everybody, don't leave it behind, do a big bubble DALK in which you remove the entire stroma and you replace it. And then we started to get stromal recurrence after big bubble DALK. And in the long term, we can get gradual recurrence above and below the donor graft. That means either in the subepithelial layer, so you can see here the anterior stromal recurrence is in your superficial layers and corresponds to a sort of whorl epitheliopathy, which is a tear film issue, and that's in the anterior stromal layer. But that's not usually as visually significant as posterior. So you can see in this patient here, you can see that quite significant recurrence deep right next door to Descemet's layer. And removing these anterior stromal recurrences easily achieved by just removing the previous donor, putting a new one on, but you've still got that posterior recurrence. So what do we do? So I'm going to present 3 cases now where the posterior stromal recurrence occurs not in the donor tissue, but in the residual predestigmatic Duas layer after big bubble surgery, where there should not be normal stroma left behind. Okay? So here's a patient, a young man, lattice dystrophy, 621, 630, severe glare. I did big bubble DALKs in 2004, 2009. He got 6/9 vision. I discharged him. It looked great, and he came back 2016, again with blurring of vision, more in the right eye. Now vision had dropped to 624 in the right eye. So if you look at the right eye, there's less of a stromal haze there. The left eye looks cloudier with stromal opacities. I detected a cataract, and I thought, okay, since the right eye, the cornea looks quite clear, I do the cataract surgery. I did the cataract surgery, and vision was still only 621. If you look very closely, and the patient complained of frosty vision after the phaco. If you look at the images, right and left, you'll see that the iris detail, and it's focused on the iris, is actually frosty. And the recurrence of this frosty haze is seen beneath the anterior stromal lesion. So if you look at the iris, it's not in clear detail. So you get a better picture during surgery. If you look at anterior segment OCT, you get anterior stromal deposits, yes, but also thickening of the predescemet's layer in both eyes. You can see here in the bottom, there is a thick asymmetrical layer, and it could be 50 or 60 microns thick. Now, I certainly didn't leave that behind the last time. This is not previous remaining posterior stroma because it was a big bubble DALK which had been successfully performed with, I thought at that time, full Descemet's bearing. So this is a regeneration. This can only be Duas layer. So I went in again, and let's see what happened. So the key, of course, and the beauty of a DALK is that you can theoretically just remove it, put a new one on, if you don't perforate. And once you find that plane, it's relatively easy to do so. And once you remove the plane, then we see this frosty layer, which is quite profoundly frosty. Can you see that? So I thought, okay, let's remove this layer. So this is Sinskey hook. You try not to do what I'm about to do, which is perforate. But you must persist, right? So you just put a little cotton bud there and you try somewhere else. And then, you still haven't learned, and you perforate again. You then adopt what I call a vibratory technique, because your hands are shaking at this time. And you try and say, okay, I'll do it one more time before. You can see that very nice vibratory action you can achieve. And then lo and behold, you start to peel. This is the marginal dissector we use for DALC, blunt tip dissector. And by this time, of course, there's so much aqueous it leaked. The chamber's nice and soft, so it's easier to form that plane. And now you can separate. And so you take your time and start peeling. So this is a real instance of Dua's layer, which is regenerated or become thicker, and in which you get granular deposits causing this frosty outline, because we never saw this during the initial procedure. And you can see underneath, it's nice and clear. This is pure Descemet's membrane. Now, most of the time we tell DALC surgeons, try not to do this because it can perforate, as I've just shown you. So at this point, I decided not to go too much. I didn't want to go right to the periphery. And we basically just peeled maybe about a 6 millimeter zone and left it like that. Okay, so of course, when you come to the previous perforation, then you have to go blind, and this is when the aqueous is there. You're not really sure whether you're in any plane at all, and you have to go by faith. But right at the end, you'll see that when we remove this, the central 5-6 millimeters, and that's all I decided to do, and you inject air, lo and behold, Dua's layer is still there. Okay, so this patient did well. You can see this is what it looked like. Frosty vision is gone. Vision is now 6.9. Pre-op was 6.21. This is what it looked like before, focusing on the iris, and this is what it looks like after we've removed that layer. So he's coming next year for the other eye. Here's a granular. That was lattice. So granular, same thing. Really nice big bubbles. You can see great results. And then after 5 years, this starts happening, and 6.21 in both eyes at 7 years. Same thing now. And I'd learned from my mistakes, so I'm trying to be a little bit more careful now. You can see that same layer now. This is lattice, so slightly different appearance, but it still looks a little bit frosty. And to cut a long story short, I didn't perforate this time. We went a little bit bolder, and you can start peeling this layer. So again, this is Dua's layer. Now, don't try this at home. We still don't recommend this because it's a high risk of perforation. But this patient did very well. We finished the dissection right across, and you can see how beautiful. This is what we call a type 2 bubble, where we really have Descemet's layer. So if you actually see Descemet's layer, it's completely afibrotic. It's very smooth, and it's very risky. It's a much weaker membrane. So this patient before and after surgery, 6.9 vision. Okay, and the third case, very similar, and this is a 70-year-old patient now with granular dystrophy, big bubble doubts in 2008, 2011, and I did the left eye, 6.6 vision, did very well. Histology, if you look at this is the DALC donor, and there is some hyaline deposits, Masson trichrome stain, yes, anteriorly, but this is that Dua's layer, and you can see it's just got lots of hyaline deposits, and it's also thickened as well. So the clinical controversy of Dua's layer, is it an anatomical layer? Well, it's definitely a layer, whether you would call it a condensation or a zone, it's semantics, but it is there, as I've shown you. If you want to put your name to something, make sure somebody else does it for you and not you, then it's fine, okay? But seriously, Dua's layer is certainly a clinical entity of surgical and pathological importance, as we understand now. Anterior stromal dystrophies who have undergone DALC can develop recurrent lesions and have a special predilection for Dua's layer. Surgeons need to understand this to manage long-term recurrences. Thank you for your attention.
Thank you, Professor Tan, for that fantastic talk. Are there any questions for Professor Tan? Yes.
Yeah.
So the question
Is that you,
is...
Michael? Hi. Yeah, it's a good question. Somebody asked me that as well. I think the question is, why don't we see the recurrence in that deep layer when we do a full thickness penetrating keratoplasty? Well, for anybody who's tried to dissect Descemet's membrane off, it's not that easy. I think there's a certain amount of adherence there. So presumably the deposits have to come in through the path of least resistance. And if you've ever separated Descemet's membrane or you peeled off a DALC, it peels off quite easily. So I think it's just that the surface tension is not that high if you've previously separated tissue. So, but you're right, we don't see it very much at all in a PK. So this is very particular to a DALC procedure.
I have a question from the floor. Is there any evidence of this layer in normal corneas? Is it just an inflammatory fibrotic response in an abnormal cornea with the added insult of surgery?
Yeah, the answer is absolutely, yeah. In Dua's original paper and subsequent people who've looked at this, these were normal human eye bank corneas without pathology. And they demonstrated this layer, all right? So definitely, it does exist. But whether you call it a layer or a condensation, it's just like Bowman's membrane, right? We call it a membrane. It's been for a long time, it's been an anterior stromal condensation of the anterior stroma. It's semantics, but it is a layer, which is anatomically important for us.
Is there variability in the thickness between eyes?
I don't think enough has been done to really demonstrate that. There are small numbers of histology and measurements, but you can't really see it. Even with your high density or anterior segment OCT, you can't see Dua's layer. It's not there to be visibly seen until you get deposits. Thank you.
Thank you very much, Professor Tan. Our next... I'd like to invite Professor Janie Wiggs up for the next lecture. Professor Janie Wiggs is an invited glaucoma update lecturer from the US. She's the Paul Austin Chandler Professor of Ophthalmology at Harvard Medical School and the Vice Chair for Clinical Research in Ophthalmology, Associate Director of the Ocular Genomics Institute, and the Director of Genetics Diagnostic Laboratory at Mass Eye and Ear. Professor Wiggs has degrees and fellowship training in biochemistry, glaucoma, and medical genetics, and is board certified in both ophthalmology and medical genetics. Her research program is focused on the discovery and characterization of genetic factors that contribute to the blinding eye disease glaucoma. Professor Wiggs' clinical controversy is normal tension glaucoma risk factors and the approach to therapy. Thank you.
Thank you. Thank you very much for that nice introduction, and it's really a pleasure to be here. I'm also going to talk about something that some people think does not exist, so it is also a bit controversial. These are my disclosures, none of which are relevant to today's talk. So normal tension glaucoma is actually felt to be a relatively common form of glaucoma that's been defined as a progressive optic neuropathy in the setting of normal intraocular pressure. But the question is, what are the contributions of IOP-independent risk factors? And is this form of glaucoma really that different mechanistically from high-tension forms of glaucoma? The collaborative normal tension glaucoma study, which is really kind of the gold standard in terms of thinking about normal tension, actually comes squarely down in the middle of this debate and suggests that lowering intraocular pressure may be beneficial in some patients with normal tension glaucoma, but that other factors in addition to intraocular pressure are likely to impact pathogenesis. So in today's talk, I thought it would be helpful to review these IOP-independent risk factors and see what kind of other types of disease mechanisms might exist for normal tension glaucoma, because of course this is important. If there are mechanisms at play that are not IOP-related, then simply treating IOP is not appropriate treatment for this type of glaucoma. So to start with, normal tension glaucoma prevalence varies among populations, with the highest prevalence in Asian populations shown here in this graph in the green bars, and the lowest prevalence in places actually like here in Australia and in Africa. So this difference in prevalence could suggest differences in background genetic effects. And a couple of studies that have been done on Asian Americans and in particular Japanese Americans, which have a very high prevalence of normal tension glaucoma, show that in Japanese Americans the prevalence is also high, suggesting in fact that there could be at least some component of genetic susceptibility to this condition related to the background genetic risk. Now, of course, we know that there are genes that contribute specifically to normal tension glaucoma. Optineurin and TBK1 are two genes that code for proteins that actually interact with each other, and individually mutations in each of these genes in fact cause autosomal dominant familial forms of normal tension glaucoma. These proteins are involved in autophagy, which is a cellular program to remove cellular debris. And interestingly, mutations in these genes also contribute to ALS or Lou Gehrig's disease. Also, when we look at genome-wide association study results for primary open-angle glaucoma, divided according to high-tension glaucoma, shown here on the top Manhattan plot, and low-tension or normal-tension glaucoma shown on the bottom, you can see that there are real differences in association or the genomic regions that are associated with the disease, where some locations, some loci in high-tension glaucoma are not present at all in low-tension glaucoma, and some genes are greatly enriched in the low-tension glaucoma or normal-tension glaucoma form. The most enriched genetic locus for normal tension glaucoma contains a gene for CDKN2BAS, which is involved in regulating the transition of a cell from apoptosis to cell division. And this, of course, can be very relevant for retinal ganglion cell apoptosis, which we think is something that's very important for normal tension glaucoma pathogenesis. Now, in addition to differences in background genetic effects and also genes that contribute differently to normal tension versus high tension glaucoma, there are other factors, other risk factors that appear to have a big impact on normal tension disease. The first is reduced ocular perfusion pressure. It was the Baltimore Eye Survey that first showed that low ocular perfusion pressure is a risk factor for glaucoma overall. And then further studies have shown that low ocular perfusion pressure in particular is a risk factor for normal tension glaucoma risk and progression. It's interesting that cardiologists now want to further lower our systemic blood pressure, which suggests that we may have a pandemic of sorts, potentially, of normal tension glaucoma, since systemic blood pressure is an important determinant of ocular perfusion pressure. Vascular endothelial dysfunction is also a very important factor for normal tension glaucoma. The vascular endothelium has an important role in autoregulation of ocular blood flow, and dysfunction can cause vascular spasm, reduced blood flow, and features of migraine and Raynaud's phenomena, which we know are associated with increased risk, in particular, of normal tension glaucoma. There are a number of molecules and molecular pathways involved in this vascular dysregulation, but at least one component that's important is the imbalance of endothelial-1, which mediates vasoconstriction, and nitric oxide, which mediates vasodilation. So reduced peripapillary vessel density is also an emerging biomarker of normal tension glaucoma measured with OCT angiography. It seems that there is in particular a lot of peripapillary vessel dropout in normal tension glaucoma. This may be related to small sort of vessel infarcts that can occur potentially also because of this vascular dysregulation. And this paper in particular shows that this vessel dropout is highly correlated with visual field defects. Another important finding, and this has been known for some time now, is that patients with normal tension glaucoma can have an adverse translaminar gradient if they have low cerebral spinal fluid pressure. And so this is something that we see potentially in people with lower body mass index, and it's been proposed, in fact, that lower CSF pressure could possibly explain the higher prevalence of normal tension glaucoma in Japanese individuals who tend to have a lower body mass index, and also the potentially lower prevalence of normal tension glaucoma in populations that have higher BMI, in particular the Beaver Dam population, which is in the United States. So there are also some differences in risk factors for progression in normal tension glaucoma. I think we're all familiar with the flame or Drance hemorrhages that occur frequently at the optic nerve head. These occur in all types of glaucoma, but in particular in normal tension, and the presence of these optic disc hemorrhages at diagnosis of normal tension glaucoma may increase the risk of progression. Also, as mentioned, history of migraine and female gender are also risk factors for normal tension glaucoma progression. So, considering that we may be looking at different clinical features in addition to different possible disease mechanisms that contribute to normal tension glaucoma, there are special considerations for treatment. Normal tension glaucoma patients, by definition, start out at lower intraocular pressure, and there's a risk potentially of overfiltration for thickness procedures like trabeculectomy. And suggesting where some glaucoma specialists now are thinking about using MIGS for treating normal tension glaucoma. The American Academy of Ophthalmology published an IRIS registry report on the usage pattern of MIGS in normal tension glaucoma and showed that the eye stent was the most commonly performed procedure in MIGS for normal tension glaucoma. In addition, Rho kinase inhibitors, or the ROCK inhibitors, appear to be particularly efficacious in IOP reduction in normal tension glaucoma, or as an add-on treatment for NTG. And this is potentially related to the fact that this medication increases nitric oxide production and potentially reducing then vascular dysregulation and increasing perfusion. So sort of attacking that vascular dysregulation mechanism. And of course, as we just discussed, there's also the potential for overtreating systemic blood pressure. So to summarize then today, this short talk, normal tension glaucoma is a relatively common form of open-angle glaucoma, although the prevalence of the disease varies greatly across populations. The disease entity is most common in Asian populations, and that's potentially due to background genetic differences and genetic effects. Some glaucoma genes specifically cause normal tension glaucoma, in particular optineurin and TBK1, and others are enriched in normal tension cases compared to high tension glaucoma, such as the CDKN2BAS locus. It seems that vascular abnormalities are important risk factors for normal tension glaucoma, indeed pointing to potentially different mechanisms of disease that would require different considerations for treatment. So lower ocular perfusion pressure, vascular endothelial cell dysfunction, and reduced peripapillary vessel density are all features that have been observed as important in normal tension glaucoma. Lower cerebral spinal fluid pressure is an important risk factor. And normal tension glaucoma risk factors for progression may differ from the high tension open-angle glaucoma, in particular things like the presence of flame hemorrhages, migraine, and female gender. And again, normal tension treatment considerations may favor MIGS for the eye stent and also the ROCK inhibitors. I'd just like to acknowledge the International Glaucoma Genetics Consortium who performed the GWAS study that I showed. Thank you very much.
Thank you very much, Janie. I have a question from the floor. Is there a known link between typical glaucomatous field loss and dementia with normal non-glaucomatous looking optic nerve heads, that is cortical field loss with dementia?
You're asking specifically about dementia and visual field loss.
Yeah.
I don't know a lot about that particular question. I do know that there has been a lot of work looking at OCT findings and dementia, and in particular nerve fiber layer thinning and correlation with some reduced cognitive function. So.
Are there any other questions from the floor? Yes.
Most illuminating talk, thank you, Janie. Do you sometimes think that normal tension glaucoma is a diagnosis of exclusion? In other words, there might be a lesion somewhere, a mass lesion?
Yeah, I think it's a complex disease, and glaucoma is a complex disease overall. But I think that there are potentially some patients diagnosed as normal tension glaucoma that perhaps previously had exposure to steroids or may have very high morning IOP pressure spikes that are not captured in the clinic and things like that. But on the other hand, I think there are truly groups of patients that do progress and have progressive optic nerve disease without ever having elevated intraocular pressure.
There was a patient I was aware of, I didn't get to meet the patient, who was said to have typical glaucomatous optic neuropathy with normal tension glaucoma, turned out to have a large cribriform plate meningioma.
Janie, I have a question. Apart from lowering the intraocular pressure, do you approach your normal tension glaucoma patients any differently? Like, for example, do you advise them to take supplements or vitamin B3, ginkgo, resveratrol? What do you think?
Yeah, that's a great question. I think that patients can certainly tolerate B vitamins and a healthy diet, and that has in some studies been shown to be potentially beneficial for optic nerve health in all types of glaucoma. And certainly there's nothing wrong with suggesting that. I think that some of the other supplements, ginkgo and some of the others, can have some adverse side effects in patients and may not be as well tolerated. And so there's clearly a risk-benefit consideration.
I have one final question. Is OSA a risk factor for normal tension glaucoma, obstructive sleep apnea?
Oh, yeah. Yeah, so sleep apnea is potentially another risk factor, and the connection there is that it may interfere also with optic nerve perfusion, ocular blood flow, and also potentially, some vasospastic kind of phenomena may also be associated with that. But again, sleep apnea is not necessarily specific for normal tension glaucoma. It does occur across all different types of glaucoma.
Thank you very much.
Thank you.
Next, I'd like to invite Professor Sarah Copeland. She's our invited oncology update lecturer from Liverpool, United Kingdom. She's a senior consultant histopathologist at the Royal Liverpool University Hospital and the George Holt Chair of Pathology at the University of Liverpool. She's a trailblazer in ophthalmic pathology, hematopathology, molecular pathology, and biobanking. She holds many leadership positions currently and in the past, both in the UK and internationally. These include the presidency of the International Society of Ophthalmic Pathology. Professor Copeland has been recognised as a top 100 influential woman in ophthalmology in 2021, and I can see that she mentors lots of people as well. Professor Copeland's clinical controversy is prognostication in uveal melanoma. Thank you.
Thank you very much for the lovely introduction. So I'll be speaking about prognostication in uveal melanoma, the techniques and why we do it, particularly as at the moment there's no curative therapeutic for metastatic uveal melanoma. I should just mention, perhaps before commencing my talk, I do lead a super-regional ophthalmic pathology service linked with one of the 3 large adult ocular oncology centres in England. And whilst uveal melanoma is a rare eye cancer, approximately 350 cases per year are seen in Liverpool by the clinicians, and consequently we see a relatively high number in the pathology department as well. So as you know, yes, uveal melanoma is a rare cancer. It arises in the iris, ciliary body, or in the choroid, with the most common location being in the choroid. It's a very vascular tumour, and it has a predilection for spreading to the liver, something that we don't really understand. And at the moment, there is no standard of care. So the process of metastasis is very complicated and something that we're still trying to understand. Interestingly, approximately, well, in 1809, James Wardrope, who was a Scottish surgeon, he described the natural history of uveal melanoma following one particular patient and wrote it up as his thesis. Later, Ernst Fuchs, who, as you all know, was an ophthalmologist, he also had a great interest in uveal melanoma, and he described this particular predilection of spread to the liver. And he put forward the so-called predisposition theory, which was then taken on by Stephen Paget 7 years later. And Paget put forward the theory, the seed and soil theory of cancer spread. And this seed and soil theory is very much used nowadays in trying to understand the biology of metastatic cancers of all types. So Fuchs, if you look up the original manuscripts, has beautiful diagrams of the morphology and the locations of the uveal melanoma, and also he looked into the staging of the tumours. And so I guess this was probably the initial beginnings of prognostication in uveal melanoma. So the largest ones occurring within the eye and their particular location were associated with metastatic disease. If we fast forward a century later, there was a landmark paper by Gabriele Prescher, based in Germany, and this group demonstrated that if you had loss of one copy of chromosome 3, monosomy 3, this was associated with an increased metastatic risk in these tumours. And so over the last 30 years, a huge amount of work has gone into the understanding of uveal melanoma. And in contrast to skin melanomas, where the initiating mutation is a BRAF mutation, what happens in uveal melanoma, the transformation between a normal melanocyte to a nevus is either a GNAQ or a GNA11 mutation. And then if you have the malignancy transformation, then you have this association of either chromosome 3 loss, 8q gain, and a BAP1 mutation, and other mutations are also listed there. And the presence of BAP1 mutation and the chromosome 3 loss is usually associated with the spread of the tumor cells in the blood and ultimately to the liver. So another landmark paper came out in 2017, and this was as a result of a collaboration of 7 different centers within the US and also in Europe. And this was published in Cancer Cell. This was the study which was led by the Cancer Genome Atlas. And extensive analyses were undertaken. Essentially, what was described was that there were 4 subgroups of uveal melanoma, which I'll go into more detail about. Simultaneously, a study in Switzerland demonstrated also that there were these essential 4 subtypes of uveal melanoma, which was associated with metastatic risk. So these are the 4 subtypes. 1 and 2 are associated with disomy 3, 3 and 4 with monosomy 3. And as you have increasing copy number alterations of 8q, then you have an increasing risk of metastasis. 1 and 2 are associated with IFAX and SF3B1 mutations, whereas groups 3 and 4 are with a BAP1 inactivating mutation. And so this was all on the basis of approximately 80 primary uveal melanomas. And then that was correlated with the clinical information, you can see quite clearly that there's with the Kaplan-Meier curves, that there's these distinct metastatic risk subgroups, and such that, for example, group 1, there is a flat line, and these patients hardly ever develop metastases. So you could combine these genetic changes to the histomorphological ones, which were initially described by Ernst Fuchs and von Greve. And you can see that you can essentially subdivide these uveal melanomas into low and high risk according to their morphology, mitotic count, presence of matrix patterns such as closed connective tissue loops, the presence of extraocular spread, and also using simple immunohistochemistry. So BAP1 immunohistochemistry is a good surrogate marker for detecting the presence of an inactivating BAP1 mutation. And so now, in most pathology labs, the BAP1 stain is performed as part of the routine diagnostics. And as you can see from this small study that we did, you can see that the presence of a nuclear BAP1 positivity is associated with a relatively good prognosis. So what we do in Liverpool is that we've worked together with clinical engineers, and we've come up with a multi-parameter prognostic algorithm which takes into account a number of features. And there's the age and the gender of the patients, the size of the tumor, its location, its histomorphology, its presence of these connective tissue loops, and also the genetic alterations. And for every single individual patient, we come up with an individualized prognostic curve, and these are produced for the patients and within the clinical team, which also includes a clinical psychologist. These curves are discussed with the patients only if they want to know the prognosis. And so this was based on huge amounts of data which was collected over the years. Our super-regional referral centre has existed for 40 years in Liverpool and was established first by Prof. D'Amato, who was had great foresight in creating this clinical database. So this algorithm is online, and you can see these were the two clinical engineers on the right, and it's been used worldwide for helping, for prognosticating in uveal melanoma patients. It's not only used on enucleation samples, but also on these tiny intraocular biopsies. So we receive these on a regular basis, every Tuesday and every Friday. And we extract the DNA from these samples and use two particular techniques at the moment to look at the chromosome 3 and chromosome 8 status. And we can, just to mention, you can use these techniques following proton beam therapy, for example. We've been able to demonstrate that the DNA is of sufficient quality to undertake these analyses. So there have been a number of different techniques, and if there are any controversies, is what type of technique should be used, and there could be quite a bit of argy-bargy going on in conferences, particularly at ARVO, as to what is the best one. However, I think the thing is, as long as these techniques are performed in an experienced laboratory with all of the associated controls, then I think there's no particular better one over the other. However, as was spoken about yesterday within the ocular oncology session, there's been a rapid evolution in molecular techniques over time, and such that we're getting more and more information from smaller and smaller samples. And so now, on the basis of those two landmark publications regarding the molecular changes in uveal melanoma, we're developing bespoke next-generation sequencing panels for uveal melanoma. And these have been developed in a number of laboratories, and some are commercially available, such as the Castle Biosciences, which is then combined with another test which looks at the PRAME status of the tumor cells. But I think, as I mentioned before, I think essentially, as long as these tests are performed in accredited labs, then the results can be applied in routine analysis. And also what is exciting is that these tests can be applied on circulating tumor cells and also circulating free DNA. So why is prognostication important in uveal melanoma? So this is the setup in Liverpool. We have the Ocular Oncology Centre, we have the pathology lab. We also interact very closely with the liver surgeons at Aintree University Hospital and also with the medical oncologists at the Clatterbridge Cancer Centre. And so prognostication is very much part of the patient pathway, only if the patients would like to know that. And so these are the reasons, essentially on the basis of whether a patient is low or high risk. The surveillance of the liver is undertaken using either ultrasound or MRI, and MRI picks up smaller lesions and is performed more regularly in those patients who are at high risk. If the metastases occur early, then the patient is referred to the liver surgeons. We are, together with the liver surgeons, we are undertaking research studies where we're looking at the circulating tumor cells to help predict the onset of the metastases before they actually occur. If the metastases arise, then the liver surgeons undertake an explorative laparoscopy, and if they are well circumscribed, then the metastases are resected. And these are two studies which demonstrated that if you resect the liver mets, then there is a prolongation of the patient's life. However, it is not curative. And similar studies have been demonstrated in Paris. If the tumors, the metastatic tumors aren't operable, then there are a number of clinical trials which have been set up within the UK and also across Europe and across the Atlantic with the International Rare Tumor Group. And there have been very exciting results using tebentafusp, which is an antibody which stimulates T cells directed against the tumor cells. And this is only effective in a particular subgroup of uveal melanoma patients which have this HLA subtype. This is the latest article which came out in mid-October, only a couple of weeks ago, demonstrating that there is improved survival in these patients when treated with tebentafusp. So we're gradually pushing back the survival curve, but unfortunately still haven't come up with a cure or with a magic bullet. So, and the final reason is that there is patient demand. So patients read about uveal melanoma before they come into the clinic, and there are patient groups such as Ocumel UK and QROM, and there is definitely the demand within the patient as to know whether they have a good or a bad uveal melanoma. So just to summarize very briefly, there are various levels in prognostication in uveal melanoma. It's not only based only on the genomic status of the tumor cells. Other factors have to be taken into account. By understanding the biology of these tumor cells, we can improve the therapies. By stratifying the patients, then we can then also modify their surveillance of the liver, and they can be either surgically operated or recruited to clinical trials. So with that, I thank you very much for your attention and happy to take questions.
Thank you very much. I have a question. What percentage of patients don't want to know?
So in Liverpool, I would say at least 50% of the patients do want to know. Mm-hmm. It's interesting that some patients initially say they don't want to know, and we record that they don't want to know that. But then afterwards they come back and they say that they'd like to have their tumor analysed. And so we then have to officially record that in the notes that they've changed their mind and that they would like to know it. So.
And I have a question here from the floor. At the present time, what is the cost of undertaking the prognostication?
So it's relatively cheap. For example, the microsatellite analysis, we're looking at a maximum of £100. Mm. So, The more expensive ones would be towards, I think, gene expression profiling is more expensive than microsatellite analysis, and similarly the next generation sequencing, but the costs of those will come down, I think, with time.
Are there any other questions?
Sarah, the exciting area of this is to be able to measure these circulating tumour cells. What's the correlation in terms of the primary tumour in the eye and our ability to actually measure these cells in the blood in terms of, obviously the work in that area I think is really important. And if we can actually do that as a routine test and in terms of measuring or looking at the more risk groups would be very interesting.
Yes, I think the jury is still out with respect to circulating tumour cells, and some groups have more experience than others. I think with the low-risk tumours, the chance of picking up any circulating tumours cells is pretty small. We did a small study where we looked at, we divided low-risk, high-risk, and frank metastases, and we could pick up circulating tumour cells in the frank metastatic group. We were able to detect circulating tumour cells in the high risk and very rare cells in the low risk. So I think we probably need to have multi-center collaborative studies to see how well the presence or absence of those cells predicts the onset of metastases in the liver.
Thank you very much. Our next speaker is Professor James Bainbridge. He's our invited retina update lecturer from London. He's a consultant retinal surgeon at Moorfields Eye Hospital and the chair of retinal studies at the University College London. He studied medicine in Cambridge and had ophthalmology training in Moorfields. His postgraduate academic training, PhD, and postdoctoral research are at UCL, and they were supported by Wellcome Trust fellowships and a UK National Institute for Health research professorship. As a surgeon scientist, he aims to protect and restore sight by developing new treatments for the diseases of the retina. His translational research extends from the laboratory to new interventional trials. His desire to translate laboratory research to impact the patient is clear in his research. Professor Bainbridge's clinical controversy is the value of face-down positioning after surgery for macular hole. Thank you.
Well, thank you very much. This is something slightly different to the subjects that were discussed earlier on. It's a bit less existential, and it's a bit of a sideline to the general research that I'd normally do in terms of new treatments. But it's a controversy about whether patients should be advised to position face down following macular surgery, macular hole surgery. That is not new, but still remains really very real. And so I was inclined to pursue that really with the enthusiasm of one of my fellows, who I think was ultimately responsible for inspiring this work. So macular holes cause severe impairment of sight, and surgery can result in favourable outcomes for holes of shorter duration, better acuity, and smaller size. Of course, with the aim of improving the outcome of surgery for macular holes, particularly the larger macular holes, for which success rates are less high, a variable period of face-down positioning may be advised. However, the value of this positioning is uncertain, and moreover, it is arduous, disabling, uncomfortable, and often unfeasible. And the perceived need to maintain a prolonged face-down position can be a serious disincentive to people considering surgery. So practice around this, advice around this varies widely, and I think it's still uncertain as to what we should really be advising. So to address this question, I want to discuss some results of our own trials addressing it and those of a Cochrane systematic review that we've recently been updating, as well as some reports from registry studies in the UK and indeed in Australia. So it was in 1991 that Neil Kelly and Robert Wendell in Sacramento, California, published their finding that vitrectomy with peeling of posterior hyaloid or epiretinal membrane and injection of SF6 gas with strict occiput up positioning for at least a week, resulted in hole closure in 60% of the 52 eyes that they included. This paper was incidentally accompanied by a somewhat dismissive editorial by Stuart Fine, arguing that a modest benefit to the poorer seeing eye rarely improved binocular vision and would rarely be expected to improve quality of life. So Kelly and Wendell hinted at proposed mechanisms for the intervention, attributing failures to inefficient gas tamponade, poor compliance and positioning, persistent or recurrent traction, or a stiff retina, but stressed that a more thorough understanding of the mechanism of closure was needed prior to widespread use of this intervention as a standard treatment. So we're now confident that the use of gas is indeed important, but the mechanism, whether that's mechanical support, surface tension, scaffolding for reparative processes, or otherwise, is still uncertain. And the dogma of a sustained long-term compulsive face-down positioning has been questioned and examined from many perspectives. The high success rates with short-acting gas or shorter durations of positioning in a number of case series has called into question the role of tamponading, and in particular the value of face-down positioning. So, in the light of the surprisingly favourable outcomes of surgery at the time, Gass updated his classification of macular hole evolution, identifying that neural tissue was not actually avulsed, but that foveal dehiscence could be repaired by surgery and gliosis. Prior to the development of OCT, Gass suggested, for the purposes of classification, that, and I quote, "since the ultimate diameter of the hole is variable, all holes less than 400 microns in diameter should be considered as stage 2 holes, that is, those with persistent vitreomacular attachment." And it's this criteria of 400 microns which came to define the threshold for larger holes, and the larger holes that typically responded less consistently to surgery. And this criteria was continued in the classification suggested by the International Vitreomacular Traction Study in 2013. Indeed, this criteria has proven remarkably accurate for prediction of outcomes, although perhaps it should be revised slightly in view of some more recent findings that I'll discuss. So, to address the question of whether face-down positioning is helpful, we started in London with a pilot trial in 2012, including 30 eyes of patients advised to position face down or randomized to a face forward position, which was the control. And the outcome of this study was anatomical hole closure. We found in this study that holes closed in 14 of 15 eyes in the posturing group, but in 9 of 15 in the non-posturing group overall. In a subgroup analysis, according to macular hole size, all the holes smaller than 400 closed regardless of positioning, but in contrast, holes larger than 400 closed in 10 of the 11 eyes. They closed in 10 of 11 eyes in the positioning group, and indeed in only 4 of the eyes in the non-positioning group. So we concluded that face-down positioning may improve the likelihood of macular hole closure, particularly in holes larger than 400, and it was these results that supported a formal clinical RCT on which it was powered, which we subsequently performed. And in this trial, it was a multi-centre trial, including 185 eyes having surgery for large holes specifically, that's those greater than 400 microns, with inner-limiting membrane peeling and with injection of C3F8 gas, because that's the only gas that we can persuade everybody to use. We randomly allocated participants with or without advice to position face down for 8 hours daily for 7 days, and all patients were advised to avoid a face-up position for that period. So without face-down positioning, there was an estimated 86% likelihood of hole closure in this group. We found no clear superiority of face-down positioning, but at the median macular hole size of 488 microns, we found an adjusted odds ratio of 3.15, a risk difference of 4.1%, and a number needed to treat of 24, consistent with the possibility of benefit. Larger hole sizes appear to have lower numbers to treat. And furthermore, we found that face-down positioning improved the secondary outcome of visual acuity by 0.2 logMAR with a statistical significance. So we were slightly cautious about over-interpreting these findings as showing conclusive benefit, but the editorial accompanying the article concluded that the data provided compelling evidence that face-down positioning leads to clinically significant benefit for holes larger than 400. So how do these results compare to other RCTs? So we've recently been updating a Cochrane systematic review as described in the slide. We also stratified by duration of positioning and performed a subgroup analysis with respect to hole size. We included 8 studies allocating a total of 709 participants. And these studies are not all directly comparable because there are significant differences in study design, including the control group treatment from no positioning to strict maintenance of or other face-forward postures, with durations varying from 3 to 10 days, and indeed differences in surgical approach with or without limiting membrane peeling and with or without cataract surgery. So whilst the overall risk of bias was low, all the eligible studies were judged to be at high or unclear risk of bias owing to absence of assessment of adherence to the prescribed intervention of face-down positioning. So following macular hole surgery, the primary outcome of successful anatomical hole closure at 1 to 6 months following surgery was reported in 95% of participants asked to face down position for at least 3 days after surgery, compared to 87% not advised to position face down. The certainty of the evidence was low, being downgraded owing to imprecision, indirectness of evidence, that is, differences in experimental intervention, specifically in durations of positioning, and inconsistency between the study populations. Meta-analysis of visual acuity and quality of life were not really possible owing to the inconsistency of the outcome metrics across the studies. In a meta-analysis, we measured no clear dosage effect of duration of positioning on hole closure, and the overall risk ratio indicated no clear benefit of face-down positioning. In a subgroup analysis, for holes which were smaller than 400 microns, there was no reported significant effect of face-down positioning on successful hole closure in any of the trials. Amongst the 327 holes of a greater size than 400, however, hole closure was noted in 94% advised to position face down and in 84% not advised to position face down, although this difference was not sufficient to prove an effect with confidence. So how do these results compare with some of the real-life findings that are reported in registry studies? Well, in the Australian-New Zealand observational cohort study, in over 2,000 patients, Rowan Essex and colleagues found that withholding positioning face down did not appear overall to lead to a 5% poorer outcome for hole closure than advice to position for any duration. However, in a subgroup analysis, the results did not exclude an effect for holes greater than 400 microns. So this leaves open the possibility that those larger holes might benefit from face-down positioning. And it turns out that 400 microns is perhaps smaller than Don Gass actually suspected in the first instance. So if the response to surgery is indeed to positioning is indeed biphasic, then it may be that 500 microns may be a more relevant threshold at which to begin considering adjunctive intervention to improve success. So in the UK, David Steele and Yorston, in this registry study through Beavers, found that hole closure remained fairly constant at around 97 to 98% for smaller holes until a size of around 500 microns in minimum linear diameter, and then appeared to reduce somewhat with increasing size. Although the surgical techniques used for holes in this database are somewhat variable, the area under the receiver-operator curve is 0.78, indicating non-random association, and hole sizes equating to the points of sensitivity and specificity were both more than 70%, indicated that the biphasic curve changed at more like 500 than 400 microns. So using their definition of larger holes in this UK registry, the findings were consistent with a possible effect of face-down positioning on hole closure in those holes of 500 or greater. So what can we conclude? Well, we can be very confident, I think, from the data so far that smaller holes of short duration can be closed very effectively with excellent outcomes, regardless of positioning face down. Overall, there is some evidence, if not compelling, to indicate confidence that face-down positioning might be helpful for larger holes. And I think it's important to stress to patients that their ability or willingness to position face down should not be a disincentive necessarily from having surgery, because there's every likelihood that their holes will close. Given the numbers needed to power a study to answer this question definitively, it seems unlikely that we will have those data available in the foreseeable future. But I think in the meantime, these data can be useful to counsel patients about whether or not they choose to position face down. I'm very grateful to all the co-authors in the Cochrane studies, and also to the RCTs that we performed in the past. Thank you very much.
Thank you very much, Professor Bainbridge. Are there any questions from the floor? So in real life, what happens around the world with positioning?
We did a study in the UK which demonstrated a real divergence of opinion. And I don't know about the situation in other countries, but I suspect it's rather similar. I think that the practice varies wildly, and I think some surgeons are quite dogmatic about their approaches, and others are more open-minded. But I hope that these data will help.
Yeah. So in your patients, if you present the evidence, what percentage will choose to position head down?
I think many of them are reassured that face-down positioning is not an essential requirement, and that the likelihood of closure is still pretty high, but probably the majority would still choose to position face down given the uncertainty of the evidence.
Could I ask a question, please? Yes. Up here at the back?
Yes.
As a former corneal surgeon, I don't know much about macular hole surgery, but if it doesn't flatten with the first surgery, do you reoperate? And if you do, what do you do differently?
So many people would offer the possibility of recurrent of further surgery, and additional techniques that have been described recently include manoeuvres with the inner limiting membrane. So if there's any membrane remaining, that might be peeled or indeed inserted into the hole. And further manoeuvres include mobilizing the hole by injection of subretinal fluid in order to release the retina from its surrounding. And indeed, there have been other reports of grafts or insertion of materials into the hole to encourage it to close. So there are a variety of additional techniques that can be used. There's little in the way of sort of high quality data in terms of randomization of those interventions, but there's lots of data in terms of case series of imaginative processes to try to improve closure of recurrent holes.
Thank you. Thank you.
Thank you very much. Our last speaker is Professor Deborah Goldstein. She's our invited uveitis update lecturer from the US and Canada, via Canada, I think. She's the Magistrat Professor of Ophthalmology and the Director of the Uveitis Service at the Northwestern University's Feinberg School of Medicine in Chicago. She trained in medicine and ophthalmology at McGill University in Montreal, Canada. She has both uveitis and ocular immunology fellowships at McGill and a second uveitis fellowship from the University of Illinois in Chicago. Professor Goldstein is widely published and has conducted many research projects. She has received numerous awards and honors, including the Lifetime Achievement Honor Award from the American Academy of Ophthalmology. And from the numerous awards she's received, it's clear that she has a passion for teaching. Professor Goldstein's clinical controversy is how important is retinal imaging in uveitis?
Thank you. It is wonderful to be here, and thank you to everybody for staying towards the end of the session. I don't even think this is a controversy. This is really just me begging on behalf of uveitis patients to use retinal imaging better in our uveitis patients. I have no relationships with any imaging companies. So I am a clinician. I teach in terms of cases. So my first case is a 41-year-old woman with intermediate uveitis. She's been followed for years by a retina practice, intermittently treated with posterior subtenon or intraocular Kenalog injections when she gets macular edema on OCT. Her workup is negative. She has vitreous cells, but no haze, no clinical vasculitis. Visual acuity is 20/20 in each eye, but she has self-referred because she says, they keep telling me my vision is fine, it's not. So here's her clinical photo just to prove to you she doesn't have any visible retinal vasculitis, and you can see there's no retinal haze. Here's her OCT. That of the right eye looks normal at first glance. The left eye, you can see that she has some CME. Here's the poor man's fluorescein angiography. You can do this with any way that you do OCT, is get a retinal thickness map. And you can see, looking at the retinal thickness map, that although the right eye OCT looked normal, it is not. The retina is thick, suggesting that there's more going on than we saw with the OCT. And here's her fluorescein angiography. She's got small and medium-sized vessel vasculitis from the disc to the aura. So this is what we describe as ferning vasculitis. It is very common in intermediate uveitis, and you will not see this clinically. The large vessels are not involved. You won't see clinical vascular sheathing, so you need to do fluorescein angiography in order to see this. So we diagnose her with intermediate uveitis and retinal vasculitis. She does very well with systemic immunomodulatory therapy, stays 20/20, but is happy with her 20/20. So our next case is a 36-year-old woman, again referred by a retina physician. I'm sorry to all the retina physicians in the audience. She's diagnosed with CME in her right eye, secondary to a central retinal vein occlusion. She received 6 anti-VEGF injections. 4 were bevacizumab and 2 were aflibercept. She developed anterior uveitis in the right eye, which was felt to be due to the aflibercept. So they stopped that, treated her with topical steroids, and then resumed the Avastin injections. She then, however, developed cystoid macular edema in her left eye. So all of a sudden, the CRVO story isn't making any sense. So her best corrected visual acuity is reduced in her right eye. She has anterior chamber cells and anterior vitreous cells in both eyes, again telling us this is not a CRVO. She has no clinical vasculitis and certainly no evidence of a retinal vein occlusion. So this was the fluorescein angiogram that I got from the referring physician, and you can see with this posterior pole angiogram, she does have some cystoid macular edema in both eyes. I'm going to tell you that when I trained back in the Paleolithic era, this was an acceptable fluorescein angiogram. It is no longer the way we do fluorescein angiography. So you can do wide field angiography in multiple ways. This case is, I used a Heidelberg, and this is a montage of wide field Heidelberg fluorescein. And you can see that she has extensive vasculitis in both eyes. So again, imaging here tells us a different story. She has bilateral intermediate uveitis, retinal vasculitis, and did well on immunomodulatory therapy. Our third case is a 29-year-old male with bilateral intermediate uveitis, anterior uveitis, and neovascularization of the disc in his right eye. Workup is suggestive of tubulointerstitial nephritis and uveitis syndrome. He is not doing well on topical steroids, so is referred to us. And you can see on this fundus photo of the right eye, he has neovascularization of the disc, and the left fundus picture isn't too exciting. Here's the fluorescein angiography of the right eye. So we see, when we look just at the posterior pole, what we expect. He has NVD, and he does have some vasculitis. Here again, wide field fluorescein is very important. He has peripheral vasculitis, but more importantly, he doesn't have peripheral ischemia. So although we see neovascularization of the disc, he doesn't need PRP, he doesn't need laser obliteration of the retina. What he needs is immunomodulatory therapy. So the fluorescein again defines the NVD, but more importantly tells us he doesn't have ischemia. We treated the inflammation, and the NVD completely resolved. Our fourth case is a 16-year-old referred for bilateral chronic anterior uveitis. He developed symptomatic anterior uveitis bilaterally after a febrile illness. He's been treated with predacetate drops. Every time they taper him, he gets worse, and he's referred 4 months after his initial symptoms. So his best corrected visual acuity is normal in both eyes, as is intraocular pressure. He has chorotic precipitates in both eyes and AC cells in both eyes. Importantly, he also has vitreous cells in both eyes and snowballs. So here is our fundus photography. It doesn't show anything particularly interesting. And here I'm looking at this, trying to convince myself that I see choroidal nodules, but this kid is super blonde, looks almost albino, so are these choroidal nodules or not? I'm not really sure. OCT is unrevealing. Fluorescein angiography is really not exciting, but here ICG is very revealing. Through the early, middle, and late ICG, we see multiple hypocyanescent or hypofluorescent spots in both eyes. So we know that this guy doesn't just have anterior uveitis, he doesn't just have anterior and intermediate uveitis, but he has real pan-uveitis, and topical steroid drops are never going to help him. We work him up. The workup is consistent with tubulointerstitial nephritis and uveitis syndrome, does well with oral prednisone, and then immunomodulatory therapy. And I didn't put in the repeat ICG, but it completely normalizes. So here, ICG was important to tell us that this was really a pan-uveitis with subclinical choroidal involvement. Our fifth case is a 64-year-old woman who's been followed for decades with birdshot and glaucoma. She's got very advanced disease. She's referred because she's still symptomatic with photopsias, although her fluorescein is unrevealing. She is on full-dose mycophenolate and low-dose prednisone. These are the very disturbing fundus photos of honestly undertreated end-stage birdshot. Very importantly, though, the EDI, the enhanced depth imaging OCT, shows profound choroidal infiltration. So I urge you, when you're doing an OCT, don't just look at the retina, look at the choroid as well. We aggressively immunosuppressed her. We put her on adalimumab, trivial increase in her prednisone, and you could see that the choroid has gone back to the normal thin choroid that we see in birdshot. So EDI is particularly helpful in patients with choroidal disease, birdshot, VKH, etc. Our sixth case is a 28-year-old woman with punctate inner choroidopathy who comes in with new photopsias in her left eye. The fundus photo shows you just the PIC lesions. I don't see anything else going on. But here's where wide-field autofluorescence is invaluable. You can see in the left eye multiple areas of hyperautofluorescence. This signifies disease activity. You could see in the OCT through those areas that we have patchy loss of ellipsoid zone in the area where there's hyperautofluorescence. This is what the eye looks like 5 weeks after a dexamethasone implant. The photopsias have gone away, and the autofluorescence has resolved. So this didn't exist when I started training, again, in the Paleolithic era, but this is a very, very useful technique. And you can see on the OCTs that while the scarring of the PIC hasn't changed, those new areas of ellipsoid loss have recovered with treatment. This is a 35-year-old Caucasian woman with PIC, again, and new photopsias in her left eye. Best corrected visual acuity is 20/20 in both eyes. The eye has no inflammation, and the OCT of her macula in the left eye is really unremarkable. But here we do wide field autofluorescence again, and you can see hyperautofluorescence. If we OCT these areas, which we don't normally OCT, you can see, again, ellipsoid loss in the areas corresponding to the hyperautofluorescence. So again, use the autofluorescence that you have to help define the patient's disease. And here she is 1 month after oral prednisone. There is recovery of the autofluorescence and recovery of the ellipsoid. So we published a short series of using blue light fundus autofluorescence to monitor acute outer retinal loss in patients with punctate inner choroidopathy. We can see the same findings finding in patients who don't have PIC, other patients can get this as well. So when you have a patient with uveitis or with anything who has new photopsias, by the way, not all photopsias or not all flashes and floaters are PVD, rule out RD. So one of the things that's very helpful, if the OCT isn't helping you, if the clinical exam isn't helping you, autofluorescence can define otherwise subclinical areas of ellipsoid loss. So in summary, OCT retinal thickness maps are the poor man's fluorescein angiography. You can see retinal thickness that you might not see in the cross-sectional cuts. OCT with EDI, extremely useful in patients with diffuse choroidal disease. So it's hard to see individual choroidal lesions sometimes unless they're large, but in VKH, in sarcoidosis, in birdshot, this is a very helpful technique. Fluorescein angiography can show you vasculitis that you can't see clinically. Remember, you can only see clinical large vessel vasculitis, so the small ferning vasculitis you won't see without a fluorescein. And we do wide field fundus autofluorescence and wide field fluorescein angiography. We don't just do the little 7 fields like we did back in the dark ages. So, and then I'm going to end with reminding you, autofluorescence, ICG, fluorescein angiography, please don't underuse imaging technology in patients with uveitis. Thank you.
Thank you very much, Professor Goldstein. Are there any questions? Do you think that we underutilize fluorescein angiography these days?
Absolutely. So when OCT came out about, 30 years ago, people got the idea that we don't need fluorescein angiography anymore. So OCT is phenomenal for looking at large cystoid macular edema, but you can see angiographic CME that you don't see on OCT. So OCT is just getting a snapshot, a split second in time, what the retina looks like at that specific microsecond. But if you look at fluorescein, especially in someone who doesn't have a good RPE, or someone who does have a good RPE, excuse me, the fluorescein dye will leak, it'll get pumped out, it'll leak, it'll get pumped out. You won't see it on OCT, but you will see it on fluorescein angiography, and then again for small vessel vasculitis.
In patient with stable intermediate uveitis, good vision, and monocular complaints, do you still routinely perform fluorescein?
Absolutely. It's a really low-risk technique. We all talk to our patients about the risks. Other than vomiting, I haven't seen any side effects on my patients. Not that I really like throwing up, but it's a worthwhile trade-off to find out if the patient has vasculitis.
And if so, 1, would you treat if vasculitis is seen? 2, how frequently would you repeat the fluorescein if no vasculitis is seen?
So I treat all vasculitis in the posterior pole. I kind of arbitrarily divide up the retina like we did for ROP, zone 1, zone 2, and zone 3. Far peripheral vasculitis I don't treat, but it tells me that I do have to watch and see if it becomes more posterior. I will always treat vasculitis in the posterior pole in zone 1 and in posterior zone 2. If I start a patient on treatment, depending what the treatment is, I will then repeat the fluorescein in probably about 4 months to see what's happened. If the patient has a completely normal fluorescein and nothing else changes on their exam, I don't necessarily repeat the fluorescein unless they develop new symptoms.
Are there any other questions?
Okay.
Yeah,
Thank you so much.
Thank you. I'd like to thank all the speakers. They've been really fantastic talks, and thank you for coming to our conference. And I think we've ended the session early. Thank you.